You're listening to the Addiction Medicine Podcast, the official podcast of the Governor's Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Hi, everyone. I'm Amy Johnson, Director of Communications for the Governor's Institute. I'm excited for today's conversation because we're joined by Dr. Corey Waller, a nationally recognized expert in substance use disorder and board certified in emergency and addiction medicine with extensive experience at the local, state, and national levels. Dr. Waller, thank you so much for sitting down with us today.
Yeah, happy to be here.
You and I last spoke 5 years ago before you presented at the Governor's Institute Spring Addiction Medicine Conference in Asheville, North Carolina. What do you see as the biggest change in the substance use disorder field over the last 5 years?
Wow, there are a few things. And so I think I would break them into probably two areas. I would say one is a better understanding of how care should be delivered. And I'll explain that a little bit probably as we go when we start to think about the new edition of the ACM criteria and how that's added some levels of care for clarity, but also consolidated a bunch and methodologically changed. I would say the difference between the third edition and the fourth edition is a little bit like the first time that we did advanced trauma life support from my emergency medicine background to like the fourth or fifth version of that is a huge leap because there was a lot of data so that we can utilize things like Socratilian logic to say that A plus B equals C and start to really connect dots utilizing data science and math rather than just a small group of experts trying to figure stuff out. So we were able to decode thousands of articles and really put it together into an evidence-based place. So I think that's one. I feel like on the other side of that coin, that we are at a pretty rapid race to the bottom from a quality standpoint. The reason being is that the payers are getting squeezed. And when the payers get squeezed, they squeeze the providers. And so the providers are trying to thin out what they can do in order to deliver things for the amount of money that they're getting. And so in doing that, we've lost really this thought process around what is not only going to save somebody's life, like an opioid use disorder, where we give them medication, you got a great mortality benefit. And that's a wonderful harm reduction first step. The problem is that we forget about the next step, which is function. So being alive, but miserable because you haven't worked on your mental health disorders or stabilized your medical disorders, or you're still, cycling through, intoxication and withdrawal sometimes because you can't quite get stable and you needed a different level of care. That's not the goal. So yes, first step, absolutely need to be alive. But we have, I think, really lost the overall conversation that the goal is actually to build a comprehensive addiction treatment system that delivers high quality and therefore gets people functional in their life in that. And so I think on one side, I think we figured out what good looks like. And on the other side, now we have to get people to actually pay what good looks like, on that. So I think those are juxtaposed right now as really philosophically complex, issues right now.
I want to ask about the ACM criteria in a second, but, just along those lines of changes, you did mention addiction treatment systems, and I know you've developed them for many practices and hospitals and for justice-involved populations. Yeah. There have been several developments in the justice system's approach over the last few years. Can you speak on that?
Yeah, this is, I think, we've seen a pretty rapid change there. And I think a lot of that is due to the court system saying that it's against ADA and it's against the Eighth Amendment. So it is not okay to not allow access to medication-assisted treatment. And every single one of those cases that have been brought by inmates who didn't have access have all ended up winning in that process. So that's really been helpful. But then we also have some really forward-thinking prison systems and and jails who have pushed the field forward quickly. And I would say the California Department of Corrections and Rehabilitation would be one of those. I think there are a number of individual jails around the country who have taken this on as recognizing their role is not just to detain somebody, but actually to identify the reason for needing to be detained. And if they do that properly, then we decrease the chances of them having a recidivating down the road. And I think that's an important concept, and more particularly figuring out how to get the custody officers to feel comfortable with the fact that we're delivering a controlled substance to a group of people who have an addiction to a controlled substance, which is sometimes a tricky conversation to have with non-medical people. It can get really squirrely if you don't explain it properly.
So I'd like to talk about the ASAM criteria that you mentioned. You're editor-in-chief of that. How do you come up with that criteria, and then how does it evolve?
Yeah, so great question. And I think the most important piece there is I don't. And that's the important piece. As one of the first things that I did is really sit down and listen to all of the people who have been historically involved in developing the ASAM criteria. Really Dr. David Mealy, David Gasfrin, Gary Schuler, Paul Early. I mean, just these amazing people who've really spent their entire careers trying to figure it out, taking what they had and then asking, how do we take that to the next level? And the next level for me was to remove the individual opinion and replace that with methodology. And so we spent a good 6 months before we started, quote, writing or delivering, just deciding on what is the most effective methodological approach so that we can build something that is both pragmatic and evidence-based. Because I think we all know that, if somebody like Gail D'Onofrio puts out an article out of Yale, that's great. But most of us don't work at Yale. And so we have to translate that into what does that look like in a community of care, and whether that community is a city, a county, a state, or a grouping of states in some parts of the U.S. that are very rural. We need to be able to translate that. So when we looked at how we're going to do that, we recognized that the biggest thing that we needed to do is everything that we could to remove the ego from the room. And the way that we do that is we first look at the literature, decode that. So we did data extraction on over 1,100 articles. After that, we then built writing groups that would build together the best in class piece of what they were working on. And independent of me, that wasn't my role. I wasn't on a writing group. I sat in on the withdrawal management group because that had started even before this. But they would then decode the literature, put that together into the construct of what that chapter would be and what those levels of care would look like. And then that would go to an outside group who would then score it. Each one of those people had to fill out, everybody who touched it, all 132 authors or co-authors, ultimately had to fill out a pretty deep background of who do you work for? Where do you get paid? Have you ever done anything with pharma or device or any of those things? And if you had, or you were actively working with a payer, you weren't allowed to vote. You could have input because we need that input from these experts. But at the same time, the voting public were those that had completely clear backgrounds. And once we did that, then that went back to the writing group, got tidied up based on that feedback, and then we sent it out for public comment, much like a federal document that would come out. And we got over 3,000 comments back, and we answered every single one of those comments. And every single one of those answers to those comments is available publicly. So you can look at those comments and see somebody said, well, we don't think blank, blank, blank. Well, the data shows this, so we we didn't change it because the data shows this. Or that's a really good point, and that doesn't meet the scope of practice requirements for that person, so we're going to modify the language to better fit that. And then after that, then we went through the full editorial process where I read from start to finish to make sure the language was the same all the way through. I think I'm on my 8th read through now of it, and making sure that the way we explained something in chapter 2 was the exact same way we explained it in chapter 12, and that the continuity was understandable. Because we found, and this was the guiding principle, was, ultimately, if what you want is the best care, you have to make the best care the easiest care. Because at scale, people are going to do the easiest thing in reality. And so we really tried to make this the easy button for regulators, for providers, and for payers alike, so that we could all speak the same language and have at least general agreement upon the pathways of care.
You mentioned evidence-based treatment. I'd like to get your opinion on so a new study based out of NC State University that was just published in the Journal of Substance Use and Addiction Treatment. Researchers wanted to know how many organizations in North Carolina that provide residential opioid substance use services actually provide patients with evidence-based treatment or allow patients to access those services. Specifically, we're talking about opioid agonist treatment like methadone and buprenorphine, right? So what the study found was evidence-based treatment is widely unavailable and even discouraged by some providers at times in North Carolina. So you have a great perch on this from a national perspective. How does this stack up with other states, and can you comment on North Carolina specifically?
Well, I can. We actually have a clinic in North Carolina, and that we just opened, and so I've had to dig into the regulatory schema and understand the payer realities and all, the licensing and oversight and all of those pieces. And so I have a pretty good understanding about what's working and what's not working as smoothly as we would hope in North Carolina. And I think that Carolina has a really good start. The expansion of Medicaid really does really helped a lot here, I think, as far as creating a system of access for patients. That was a big win for the communities out there. And I will say that evidence-based care, people listening to this, I'm giving air quotes on this, because people throw that around like it has a meaning, right? So let's define that first. So evidence-based care has, in my mind, 3 tiers of evidence. And so the first one is, you'll hear me say this all the time, data, science, and math. So the data is, do we have, a randomized control trial, a meta-analysis, a Cochrane database review, right? That's the pinnacle of kind of, based on everything that we can do, we have, shown that doing this is better than doing nothing. And that's really, the first piece. So the clear winners in that place for opioid use disorder are methadone and buprenorphine, and a little bit farther behind that is naltrexone. But there's some caveats to that. Still very helpful for the people that it's right for. But what we forget to talk about is the fact that opioid use disorder is one of many disorders. And while buprenorphine and methadone probably have the best evidence having a direct connection to somebody taking it and having a lower risk of dying than anything else we do in healthcare. It's pretty crazy, the direct line that it is. It's better than aspirin. It's better than me shocking you, with if you're in VTAC. So it's a really helpful tool in the toolbox. But then we shy away a little about what is psychoeducation and who should deliver that? What is psychotherapy and who should deliver that? Because we use these very vague terms, not only in residential, but in the outpatient space of things like counselor. Even in the regulatory path, we do this. And then who can be a counselor? Is it a peer? Is it a CDAC, somebody with an associate's degree? Is it a bachelor's person? Is it a master's? Or is it an independently licensed master's level person? I mean, at the end of the day, when you dig in, and I've had an opportunity in my previous careers to see a few hundred providers, deliver this care around the country. And I have yet to identify one that the system is built to deliver evidence-based care to fidelity. Not one. And that includes mine. And just to be honest, we're working on it and we're defining it and we're breaking it down. But one of the pieces that I would say we have to do is hold people accountable. And the best way to hold them accountable is if I was in charge for a day I would not pay places that don't use evidence-based medicine. I would just say we don't pay for things that don't work. And are there exceptions to that? Sure. Absolutely. Are there people who don't need medication? Sure. Are there people who do better in a 12-step program outside of a standard, quote, evidence-based treatment? Yeah, there really are. So we're not talking about absolutism, but 100% of people should have access. 100% of people should have the option. And I think that's what we're talking about. And when somebody says, I'm going to deliver, quote, therapy, we're paying for stuff that's not therapy. It's like rent-a-friend. And so at the end of the day, if you're not delivering a validated, methodologically driven psychoeducational program, you're kind of not doing anything, because they need to leave with a skill. They need to leave with the ability to make their life better, to walk in the parking lot and have skills that keep them from wanting to use, to help skills to keep them from saying yes when somebody offers it to them. And if they don't have the insight that they need those skills, then they need therapy. And a therapist is somebody who's trained in therapy, and it's trauma-based cognitive behavioral therapy, dialectical behavioral therapy, eye movement desensitization and reprocessing therapy, real therapies that have good data. But real therapy requires time and motivation to get there. So everybody who says they use evidence-based care, when you really start to lift up the lid and take a deep dive, it's just not where we want it to be. We're on the journey, but we really need for payers to help us here, in a sense that we need them. I would challenge regulators and payers to not license or to not pay for care that hasn't been shown to help people. We have a small amount of money to do a lot of heavy lifting. And it's been really tough to see this happen, where they're spending $100 million in sub-states for stuff that has no evidence behind it. So I think that's where I would probably put a pretty heavy stake in the ground on the evidence-based cares, to just hold ourselves responsible for that when we use those words, to actually know what they mean, and then apply it to the totality of care, and not just to, did I get them a pill or something?
So you oversee medical team education.
Yeah.
What one or two things are critical to impart on new or young or even all doctors today?
Well, so I have to, and again, I'll bring you back in kind of the totality of education, because it's not just about doctors. This is a team sport, man. This is fully team required for this. So you can have the smartest, quadruple board certified, blah, blah, blah. They can't do it themselves. I have spent my entire career learning about this and trying to understand it, and reading book after book after book to try to figure out this, and trying, working with patients and going to seminars and learning from really smart people. I'm still not all they need. Like, if I opened up a clinic tomorrow and hung a shingle, I still need somebody dedicated to psychoeducation. I still need somebody dedicated to good case care management. I still need somebody who knows how to do true psychotherapy on a consistent basis. And so the education starts with, one, what is your role and what is it not? So we spend a lot of time making sure that people understand, what is your scope of practice? Not in a mean way, not in a hierarchical way. It's just that if you're an associate's degree like CDAC, and you say, I want to do therapy, my answer is, please don't. And I'm going to say that not because somebody's not capable of figuring it out and doing it. I'm saying that because they're actually just purpose built for psychoeducation, which has great outcomes. If you're a master's level therapist, I don't want you to do it. I don't want you to dedicate your time to just doing psychoeducation, because you're going to ruin it. You're going to invalidate it, because you're going to hear something, or you're going to see something psychodynamically, and you're going to say, wait a second. And then you're going to invalidate the whole psychoeducation program, because you're going to veer into therapy, and it's not going to be delivered at fidelity. And so our education starts with, what is your job? And I think that's a really important piece. After that, I think the core concept, comes down to, you need to define what you do as a clinic. And so if we're talking at the global, like, what should any clinic think about, or a clinician? If you are a residential treatment provider at a level 3.7, you should know everything about withdrawal management. Everything. And I don't just mean this drug at this dose. I mean, what receptor does it hit? What other receptors does it overload? what are the side effects of these 4 other medications? If you can't tell me all the pharmacology of the things you're putting in that person, that's pretty scary. And we all think that they all know it, right? We all think we all learned it in medical school. We did not. We did not. We got an inch deep and a mile wide in medical school, and then we dug in a little deeper over time. But these are skills that are really important to understand. And so if you're working at a specific level of care, you really have to know that level of care backwards and forwards. So if I'm teaching physicians, that is deep pharmacology and a whole bunch of infectious disease. Because, we need to treat not only addiction, but the addiction adjacent illnesses that come along with this. And so hepatitis C, HIV, liver failure, heart infections and IV, all of these things, STIs, we should own that space. It's just disproportionately found in our population. And so those are things that we think are really important. But if I was to pick like one that covers all of those, other than know your scope of practice, it's going to be motivational interviewing, 100%. 100%. If you can't do that, quite honestly, you're going to be terrible at this job. And again, you can know everything in all these books back here, but it doesn't matter. If you can't interact with the patient in an empathetic and meaningful way, the way that this disease modifies the brain, you will create an increase in their mortality risk because you will make them feel guilty. You will make them feel shame. You will make them worse than they were when they walked in the door. And so if there was one thing I would mandate, it's 36 hours of, motivational interviewing training, which should happen at the beginning of every training program, but it doesn't. So that would be the biggest and most focused thing.
Can you give us a sneak peek at what you'll be presenting on at the Governor's Institute's Virtual Addiction Medicine Essentials Conference in October?
Well, first, I'm going to have to say the title super fast so that I have time to go through the legs. That's a lot of words. But no, I think the goal here is to really try to anchor the conceptual framework of the ASAM criteria and how that looks and what is the future of addiction medicine, where a person can walk into any one of the clinics at any level of care and get the core conceptual pieces of the initiation of care, the level of care determination, and a treatment plan. And either we get them to the right place in a patient-centered way, or we treat them in place as the best we can, but we do it to fidelity. And so I'm going to talk about a philosophical framework and then the data-based framework around that. And then I think more importantly, the practical application of this out in the real world. That's the world I live in. I have 80 plus clinics with thousands of employees and 23,000 patients that I have to think about before I go to sleep every night. And when we look at that, our goal is to make sure that the system is built to fidelity, that people are trained to deliver the care that we ask them to within their scope of practice, and that a patient feels heard and gets every access to being better that they can. And the goal of this talk is really to get people's mind in the place of, here is where we're going, and we need you to come along.
Thank you so much. Well, thank you, Dr. Waller, for sitting down with us today. I think this was a great conversation. We really appreciate it.
Oh, happy to do it. Looking forward to the talk. I wish it was back in Asheville again. I hate that it's remote, but I understand.
Thank you to our listeners for joining us today. If you like this podcast, check out some of the other episodes in the Governor's Institute's Addiction Medicine podcast and subscribe.